السلام عليكم ورحمة الله. أنا دكتور أحمد D Abdulwahab, أخصائي الأشعة, and this is Highlights in Radiology. First of all, I want to say thank you all for your amazing comments and your amazing watch time and your amazing subscriptions in regards to the episode 1 of Highlights in Radiology. And I promise you, if we keep this, if you keep this support to me by doing more subscriptions and more sharing and more comments and more suggestions and criticizing what we are presenting, I will keep on doing that, and we will keep on presenting highlights in radiology in its current form, which is like episodes of around 10 to 20 minutes each, discussing a certain topic. And in the last episode, I asked you to give us your opinion and to suggest what should we do in the coming episodes. So one of my dearest friends suggested the topic of phacomatosis. Phacomatosis, it was a big subject, big topic that has a lot of syndromes underlying it. So when I tried to do it, I discovered it was impossible to do it in one episode. So that's why we will do it in 2, maybe 3 episodes in the future. So today will be the episode 2A of phacomatosis. And I would like your comments and your opinions about it and your questions. Just write them in the comment section in YouTube, and we will continue these things, these episodes and much more in the coming weeks, inshallah. So phacomatosis, what's the definition of phacomatosis? Phacomatosis is defined as they are neurocutaneous syndromes. Neurocutaneous syndromes. So it has neuro part, that's CNS part, cutaneous skin parts. So in other words, in easier term, there are diseases or syndromes that are characterized by involvement of structures that arise from the embryonic ectoderm. So this ectoderm thing, and what does it mean? Embryonic ectoderm means basically diseases affecting central nervous system, skin and eye. So we have central nervous system, skin and eye involvement. And of course, other systems also may be involved, other organs in the body. So, in fact, the word phaco means, in Latin, it means eye. So, phacomatosis is basically disease of the eye. However, the exact scientific definition is diseases that involves the skin, the eye, and the central nervous system. So, let's divide these into, there are a lot of syndromes. All of them involves falls into the category of phacomatosis. We will divide them into common and less common. So, common syndromes, the most common syndromes are neurofibromatosis type 1, neurofibromatosis type 2, tuberous sclerosis, Sturge-Weber syndrome, or what's called encephalotrigeminal angiomatosis, and von Hippel-Lindau disease, which are also called the retinocerebellar angiomatosis. So we have a neurofibromatosis type 1, type 2, tuberous sclerosis, Sturge-Weber, and von Hippel-Lindau. In this episode, we will talk about neurofibromatosis type 1 and type 2, and we'll leave the rest for the coming episodes, tuberous sclerosis, Sturge-Weber, and von Hippel-Lindau. The less common syndromes are way more, a lot, and they are very rare, and we rarely see them. So just to have a quick look about them, for example, there's ataxia telangiectasia, incontinentia pigmenti, basal cell nevus syndrome, Weber-Mason syndrome, and a lot of syndromes like, for example, face syndrome, Codin disease, and a lot. Each of them has its own clinical presentation and its own findings, all of them characterized by skin, CNS, and eye involvement. So we will not talk about them because they are way rarer and we don't have the time or the space to discuss them and describe them. So let's start with the neurofibromatosis type 1. In neurofibromatosis type 1, the other name of this disease is also called von Recklinghausen disease, von Recklinghausen syndrome, or von Recklinghausen disease. It's a multi-system neurocutaneous disorder. Neurocutaneous, skin and CNS. and multi-system involvement. And it is the most common phacomatosis by far, very common. It is one of the most common inherited CNS disorders, one of the most common inherited autosomal dominant disorders, and one of the most common inherited tumor syndromes. So it's one of the most common neuro syndromes, one of the most common autosomal dominant, and one of the most common CNS disorder. It's very common. What are the manifestation of that? The systemic manifestation includes breast manifestations, CNS manifestations, cutaneous manifestations, basically skin, eye, and CNS, also musculoskeletal manifestation, pulmonary manifestation, and orbital manifestations. So let's start with them step by step. To make the diagnosis of a neurofibromatosis, the clinical guide is to have two or more of these. Two or more of these things. What are these things? These as follows. First of all, more than two neurofibromas or more than one plexiform neurofibroma. Plexiform neurofibroma basically is a giant neurofibroma, like a really big neurofibroma. It's called plexiform neurofibroma, or more than two neurofibromas. Optic nerve glioma. Distinctive osseous lesions. What do we mean by distinctive osseous lesions? We mean either sphenoidal dysplasia, thinning of long bone cortex. These are distinctive for neurofibromatosis. Also, we have more than 6 cafe au lait spots. Cafe au lait spots, okay? More than 6. Cafe au lait spots are skin patches that looks like cafe au lait, the color of it, okay? So if we have more than 6 cafe au lait spots during 1 year, pre-pubertal, they should be more than half a centimeter in diameter. If it's post-pubertal, there should be more than 1.5 centimeter in size. Also axillary or inguinal freckling, two or more iris hamartomas, what's called leash nodule. Leash nodules, we need 2 or more. Also a primary relative, a close relative, first degree relative with neurofibromatosis type 1. So if we collect 2 or more of these, okay, 2 or more of these features, you have a diagnosis of a neurofibromatosis type 1. Now, let's talk about the neoplasms that we will see or face in neurofibromatosis type 1. First of all, we have pheochromocytoma. Pheochromocytoma, as we all know, it's a disease of the adrenal gland. So you can see a tumor of the adrenal gland that secretes adrenaline and adrenergic hormones. These are pheochromocytoma, and one of the diseases that we see in neurofibromatosis type 1 is pheochromocytoma. Also, malignant peripheral nerve sheath tumors. You can see there are nerve sheath tumors that are peripheral and they are malignant in nature. By imaging, you can see they are enhancing, they are invading, they are destructing, they are extending along different areas or compartments of the body. For example, here in the gluteal region and here in the neck, they are malignant nerve sheath tumors. Also, we have Wilms tumor, which is basically a tumor of the kidney. You can see this big Wilms tumor here, tumor of the kidney. You can see also here, usually in the pediatric age group. Again, we have a rhabdomyosarcoma. Rhabdomyosarcoma, it's disease or malignancy of the muscles, which is malignant. For example, here in the abdomen and here in the hand, you can see rhabdomyosarcoma tumors. Renal angiomyolipoma, as we all know, renal angiomyolipoma is a tumor, benign. It involves the kidney containing a high percentage of fat, and it bleeds heavily if it is large in size. Okay, also again we have the juvenile multiple types of gliomas, like juvenile pilocytic astrocytoma, like here, for example, in this case we have the juvenile pilocytic astrocytoma with enhancing nodule and peripheral cystic component, and it's low-grade astrocytoma. Again, optic nerve glioma, you can see here optic nerve glioma extending along the pathway of the optic nerve and making the optic foramen much larger, optic nerve glioma. Diffuse brainstem astrocytoma, as you can see here, the brainstem is all involved with diffuse astrocytoma, and other neoplasm characteristic of neurofibromatosis is spinal astrocytoma and spinal pilocytic astrocytoma. You can see here this is spinal astrocytoma, spinal cord involvement, and again the spinal pilocytic astrocytoma. What are other pathologies or other malignancies that we see throughout the body? Carcinoid tumor, you can see here, this is carcinoid tumor of the bowel. You can see the spoke wheel appearance with its typical attachment to the small bowel loops. Again, you can see it here with its spoke wheel appearance with attachment to the adjacent bowel loops. Other neoplasms characteristic of neurofibromatosis type 1 is leiomyoma and leiomyosarcoma, which is again benign and malignant tumors of the muscles, leiomyoma and leiomyosarcoma, as in this example demonstrated here. And ganglioglioma is also characteristics like here. Ganglioglioma, it's a disease of the brain. You can see it's one of the types of gliomas. So we have different types of gliomas like ganglioglioma, like nerve sheath glioma, brainstem glioma, pilocytic astrocytoma. All of them are characteristic of neurofibromatosis type 1. So now regarding the breast manifestations, basically there are a lot of subcutaneous neurofibromas affecting the skin. There are subcutaneous neurofibromas affecting the breast, a lot. So in mammography they will be as well-defined benign appearing masses, like here there are multiple innumerable benign appearing masses all over the breast, sometimes with a halo if they are surrounded by air, if they are close to the skin. And the ultrasound will show you something that looks like a neurofibroma. If you see it, it basically looks like a neurofibroma, even containing some posterior acoustic enhancement. It looks like fibroadenoma. I'm so sorry. Basically, you'll do an ultrasound and you'll see a lot of lesions that looks like fibroadenomas. Even some posterior acoustic enhancement you can see in it, but they are not. They are not fibroadenomas. They are multiple neurofibromas. So breast manifestations include innumerable subcutaneous neurofibromas affecting both breast, as in this example. Now, regarding central nervous system, which is one of the main systems involved in the neurofibromatosis, first of all, we'll see what's known as FASI. FASI, F-A-S-I. This is short for focal areas of signal intensity, FASI. These are deep white matter and basal ganglia or corpus callosum areas of T2 or flare hyperintensity with no contrast enhancement. Basically areas of flare or T2 hyperintensity, and there is no post-contrast enhancement. Also, like here, for example, you can see there is an areas of deep white matter, areas of T2 hyperintensity with no post-contrast enhancement and no mass effect. They are one of the features seen in neurofibromatosis type 1. Also the optic nerve glioma, like we saw in the previous example, and again we can see it here. This is the optic nerve, and it's involved by a tumor all the way its length. This is neurofibromatosis, optic nerve glioma. Progressive sphenoid wing dysplasia is a skeletal manifestation that affects the sphenoid wing, called sphenoid wing dysplasia. You can see this sphenoid wing here. You can see this sphenoid wing here. It's dysplastic. There's progressive sphenoid wing dysplasia. These are one of the features of neurofibromatosis. Also, we have what's called J-shaped celli, like here. You can see the cella turcica here is of abnormal J-shaped. These are also criteria of neurofibromatosis type 1. Lambdoid suture defects, also we can see them, and dural calcification at the vertex, also we can see them. Rarely we see the moya-moya phenomena. As you know, moya-moya phenomena is a puff of smoke, it means, and basically what we see is very small hypoplastic cerebral MCA and ACA and PCA vessels. So we don't see the cerebral vessels, they are very narrow. It's a type of vasculitis, moya-moya disease. Also, we see some ophthalmologic abnormalities, including booth-thalmus. Booth-thalmus, as in this case, you can see this eye is of abnormal shape. It's large, widened, elongated, whatever you can call it. And the other eye is totally collapsed and calcified. Of course, this one is the what we call booth-thalmus. These are the central nervous system manifestations of neurofibromatosis type 1. Now let's talk about the cutaneous manifestations of neurofibromatosis type 1. This is a 3D representation of the chest of the patient. You can see the multiple innumerable skin neurofibromas, which are basically benign peripheral nerve sheath tumors. In fact, this X-ray is one of the common X-ray that the examiner loves to show it in the exams. What are these? These are neurofibromatosis or neurofibromas in patients with neurofibromatosis. Also in the axial lung window, you can see the number and the size, variable size and number of the benign cutaneous neurofibromas. Now, regarding the skeletal manifestations, we have a lot of skeletal manifestations. First of all, we have kyphoscoliosis. You can see the kyphoscoliosis here, and the X-ray of it looks like that in patients with obviously a lot of cutaneous neurofibromas. Here, this is typical diagnostic of a neurofibromatosis case. Also, posterior vertebral scalloping. You see this appearance. You can see the posterior part of the vertebra is scalloped, posterior vertebral scalloping. Also, you see it in neurofibromatosis type 1. And hypoplastic posterior element as a result of this vertebral scalloping. The posterior elements will be small, thin, and hypoplastic, like here. Also, what else do we see? We see enlarged neural foramina. Of course, you can see enlarged neural foramina and ribbon rib deformity or rib notching and dysplasia. You can see these ribs are ribbon-like. They are flat, they are narrow, they are long, and rib notching. You can see also here the ribs are notched due to the presence of neurofibromas in the nerves, in the subcostal nerves. And you can see also what's called dural ectasia. And in fact, in my opinion, it's the dural ectasia that causes the posterior vertebral scalloping. What do we mean by dural ectasia? The dura is wide and enlarged, resulting in scalloping or remodeling of the posterior aspect of the vertebrae. So there is dural ectasia and posterior vertebral scalloping, and this results in hypoplastic posterior element and widened in neural foramina. What else? What other musculoskeletal manifestations? We have the tibial pseudoarthrosis or even ulnar pseudoarthrosis. You have this, it's like a fracture of the tibia that forms kind of a joint. Also here, fracture of the fibula that forms type of a joint. This is called pseudoarthrosis. It's not real arthrosis. Also severe bowing and gracile bone. As you can see here, this is even pseudoarthrosis in the hand, with the bones are bowed and they are gracile. Gracile means thin or not strong or I don't know, easily bent bones. Like here, for example, there's again pseudoarthrosis, and we have multiple non-ossifying neurofibromas. Multiple non-ossifying non-ossifying fibromas. As you know, the fibromas are bone defect. This is a bone defect that usually we see it as a benign finding in younger age group patients that with progressing age they undergo ossification. Here we have non-ossifying non-ossifying fibromas of the bone that are multiple. Also, it's skeletal manifestation of a neurofibromatosis. Multiple non-ossifying fibromas. If we see one non-ossifying fibroma, this is just a normal, non-significant pathology, let's say. As the patient grows up in age, it will ossify and becomes ossifying fibromas. And finally, we see limb hemihypertrophy. That is, we have one limb that is much bigger and hypertrophied compared to the other limbs. So we have unilateral hemihypertrophy. Okay. Okay, so what other manifestations that we see commonly in a neurofibromatosis type 1? We have thoracic manifestations. Thoracic manifestations include mediastinal masses. which are basically neurofibromas that arises from the mediastinum, as you can see here and there are multiple mediastinal masses in the chest. And lateral thoracic meningoceles. Lateral thoracic meningoceles, they are typically on the convex side of scoliosis. When you see scoliosis, on the convex side of scoliosis, you see meningoceles bulging into the thorax from the lateral aspect. So they are lateral thoracic meningoceles, okay? In the chest x-rays again. And we have extraadrenal pheochromocytomas, or what's called paraganglioma. Like for example, here you can see this tumor turned out to be a pheochromocytoma or paraganglioma that is not in the adrenal gland. It's extraadrenal pheochromocytomas, okay? And lung parenchymal disease, including diffuse interstitial fibrosis, like you see here or you see here. And it's this interstitial fibrosis is usually more prominent in the lower zone. You can see the lower zones are involved more than the upper zones in neurofibromatosis. And on the opposite side, on the upper zones, we see multiple bullae formation. You can see here, for example, these are multiple bullae formed in the upper zone of the lungs. The last manifestation is secondary pulmonary intra-arterial hypertension, or called pulmonale. And as you can see here, these are the x-rays of patients with secondary pulmonary hypertension, or called pulmonale, and you can see the prominent the straightened heart border due to pulmonary hypertension, and the paucity of the vessels in the lungs here and there. And in the CT scan, you can easily appreciate that the pulmonary trunk is much larger than the aorta due to presence of pulmonary arterial hypertension. Now, vascular manifestations, which are the last thing that we talk about in neurofibromatosis type 1, they include aneurysms like arteriovenous and arteriovenous malformations. Aneurysms can be anywhere. For example, you can see here this intracerebral aneurysm in this digital subtraction angiography. You can see aneurysm of the left common iliac artery, basilar tip aneurysm here. There are multiple aneurysms all over, and they are of course liable to rupture and bleeding. Also arteriovenous malformations, like you can see in this brain. This is typical features of arteriovenous malformation. Renal artery stenosis, as you all know, it's one of the causes of severe hypertension in young age patients. So every young age patient with hypertension should have the renal artery stenosis excluded as a cause of the hypertension. This is an abdomen MRA. You can see the renal artery focal node or stenosed. And lastly, correctation of the aorta. As you can see in this digital subtraction angiography, you can see the area of correctation and the development of multiple collateral circulation. Now, regarding neurofibromatosis type 2, thank God for us, it's much easier to understand or to memorize than neurofibromatosis type 1. It is a rare autosomal dominant, okay? Rare autosomal dominant disease. There are multiple CNS tumors. However, there are no neurofibromas. Multiple CNS tumors, it's not associated with the neurofibromas. Instead, the patients have intracranial schwannomas, intracranial and spinal meningiomas, intraspinal intramedullary ependymomas. So we have schwannomas, meningiomas, and ependymomas. No neurofibromas. Okay? No neurofibromas. So someone might ask, if it is there are no neurofibromas, why do we call it neurofibromatosis? Well, that's a very clever question. It's a misnomer. It's a wrong name. Why did we choose this name? Because before they thought that neurofibromatosis type 2, it is a central type of neurofibromatosis type 1. So neurofibromatosis type 1 is a peripheral type that involves the skin and the viscera and the peripheral organs, while neurofibromatosis type 2 is a central type. And later they found out that neurofibromatosis type 2 has no neurofibromas. It's just schwannomas and ependymomas and meningiomas. The name kept on, and we still know it as neurofibromatosis type 2. So, to diagnose neurofibromatosis type 2, we need bilateral vestibular schwannomas. Bilateral vestibular schwannomas are diagnostic of neurofibromatosis type 2. When you see bilateral vestibular schwannomas, that's it. It's diagnostic of NF2. Okay? But care should be taken because bilateral internal acoustic meatai masses, okay? Not all bilateral internal acoustic meatai masses are vestibular schwannomas. Sometimes they are, in cases of sarcoidosis or metastasis, they can be bilateral, so be careful. It's not always neurofibromatosis type 2, but if you see bilateral vestibular schwannomas, it's diagnostic of NF2. So the radiographic features, as we said, we have meningiomas, schwannomas, and ependymomas. Meningiomas, we'll talk about them. Schwannomas, they usually arise from the inferior vestibular division of the vestibulocochlear nerve and can also arise from the facial nerve. The inferior vestibular division of vestibulocochlear nerve and from the facial nerve. So we can see vestibular schwannomas as again from the inferior vestibular division of the vestibulocochlear nerve and also can arise from the facial nerve. Now, in this case, we can see easily these are multiple and innumerable meningiomas. We will not talk about the radiographic criteria of meningiomas. Maybe we'll do another episode just talking about specifically meningiomas. However, they are dural based, they are homogeneously vividly enhancing, there is a dural tail sign. These are multiple intracranial meningiomas that are typical for NF2. Again, we can see here bilateral vestibular schwannomas. You can see this vestibular schwannoma extending into the internal acoustic meatus. Again, you can see another one here extending into the internal acoustic meatus, diagnostic of NF2. In the MRI, also you can see this vestibular schwannoma extending into the internal acoustic meatus. They are diagnostic if they are bilateral. Unilateral is not diagnostic, just bilateral. Also, we can see here paragangliomas. You can see, for example, this one here. Okay, and we can see also the ependymomas, multiple ependymomas. You can see here in the posterior fossa ependymoma here in the in the fourth ventricle and the cerebellum. This is ependymomas. You can see the post-contrast enhancement pattern of the ependymoma. You can see it obviously showing diffuse kind of heterogeneous post-contrast enhancement. And these are all the radiology criteria of a neurofibromatosis type 2. Thank God it's much easier, much less, and much more specific. All you need to do is listen to the episode, tell me what you think, comment on it, like it, share it, subscribe, and tell me your suggestions for the next or coming episodes. I have a lot in mind and I want to present these highlights to you on a weekly basis, and if we have good let's say feedback, we might do it twice a week and try to cover as many topics as we can in the coming weeks. Maybe we do it twice or even 3 times a week if you like. So thank you very much. Don't forget to subscribe and share, and see you next week إن شاء الله. أنا دكتور أحمد ضياء عبد الوهاب، أخصائي الأشعة التشخيصية. شكرا جزيلا.